How are you doing?
Well, you got my message.
Yeah.
It's time, isn't it? It's age and time, David.
Indeed, we're all getting older.
Yeah.
Did you like my arc of knowledge?
I loved it. I was reading it out to Steve. My husband is a mathematician. Loved it.
The arc of knowledge.
Yeah.
That you get to.
I was a bit taken aback. I must admit, I was rather taken aback. Thought we got past those years. Says she that lives in an ideal world.
So the more I learn about this, the more I realise I don't know.
Yeah, but you have humility. Right, Alan, what are we? Are we live?
Okay, that's us shown as being live on Facebook. Right. So again, welcome to another question and answer session, hosted again by our CEO, Collette Thain. And today we're delighted to be joined by Professor David Jones. So again, I hope you have an interesting and informative session, and I will catch up with you all later on.
Lovely, thanks, Alan.
Bye.
Bye. Thank you, Alan. Hello, good afternoon, everybody, and good afternoon, David. It's always a joy to have you in these things.
Unlike Ant and Dec, I'm not going to mention any Christmas parties. Prime Minister.
Oh, you just couldn't
now.
Could you? You could not make it up. But anyway, David, people know you've not been very well. You've had COVID and all this.
Indeed.
And sending you lovely messages, but you're looking well.
And 11 days of no power after Storm Arwen.
Oh, I know. I think it's gone again up north to Scotland, some places. So good afternoon, everybody. Welcome. I know I'm not meant to be here, but this is one of my joyous jobs, so I've chosen to be here. I know I'm a doctor's orders to go away and play the traffic, but anyway, I wanted to do this today. This is the last of our year. The next doctor session we have is on the 13th of January. And guess who? We've got our pal David again. So great stuff. So I'm going to get fired in. David, I think you've got a copy of some of the questions. Some that are a bit ambiguous.
Yes.
I'm going to try and clarify, and Linda will let me know of any updates that we have. So firstly, the effects of PBC on taking UDCA. Are there any on the fingers and nails? Now, I don't know what those effects might be, but is it possible?
Yeah, so not UDCA, I don't think. So the best way to think about UDCA is that it returns your physiology to normal. So we talk about physiology. That's the way the body works. And a classic example of kind of physiology treatment is where people take thyroxine for thyroid disease. So when you've got thyroid disease, your body doesn't produce thyroxine, which your body needs. So we give thyroxine as a tablet. So it's not really a treatment, it's a normalization. So it's giving back something which should be there. And so urso is a little bit like that. That's why it's kind of almost like a vitamin, because it's something which should be there in your body, it isn't. And we therefore give it in higher levels. And so it's for that reason, it's kind of very free of side effects. The only kind of side effects it has are in the gut, because the main side effects are in the gut, because you don't normally have such a high level in your stomach, so you need to get it into the system. Now, in terms of nails, you can get nail problems with any sort of chronic condition. So it can be part of these, part of any condition. So if you look at people with long-term lung problems and things like that, they can sometimes get nail changes. So it's kind of one of those things in your body which is a health marker. There is something very specific in PBC though, which is that you can get what are called cuticle changes. So the cuticle is the kind of bit around your nail, and you can PBC, as people will know, is an immune condition, and it's associated with some other immune conditions. And one of those is a thing called CREST syndrome. And it's never really bad in PBC, but it can be a nuisance. And one of the things it does do is cause some raggedness of the nails. That's one of the areas it affects, part of Raynaud's actually, where you get sort of cold fingers. And so it gets a bit oxygen starved. So anybody who's got nail changes in PBC, if it's around the nail edge, then it's usually part of the spectrum of Raynaud's. You sometimes get some pitting and ridging of the nails themselves, and that's something we often see in psoriasis. And even in people who haven't got skin disease in psoriasis, strangely enough, the only manifestation of psoriasis you could have is the nail changes. And as we know from work done by the foundation many years ago with Oliver James in the case control study, psoriasis is quite a bit commoner in PBC than it is in the otherwise normal population. So my best bet is not urso, but it could be related to sort of some of the associated mild inflammation sort of changes you get in PBC. But as I said, one of the things people often worry about, lupus-like features, SLE, or CREST and systemic sclerosis and all these things. People mention those terms because they can be quite significant illnesses, but they are never ever, in my experience, severe in PBC. It's I think we've talked about before, which is my theory of pick and mix autoimmunity, which is pick and mix autoimmunity, which is if the immune system is focusing on 2 or 3 different things, liver and joints and skin, it means that it has less energy to affect any of them. So sometimes the more other features that are going on, the milder each of those things is. So strangely, in many ways, it's the people with nothing other than PBC who sometimes have the most changes. So I think the important message is don't worry about the associated autoimmune conditions. The only 2 which can be troublesome are, if you don't diagnose them, are thyroid disease, and clearly anybody who gains weight or has particular problems with fatigue, which is obviously something that PBC patients are aware of, or also, and in particular if you get heat things where you're getting very cold, always get your thyroid checked. I mean, we probably start somebody on thyroid treatment once a month in the clinic. It regularly happens. It's a big association. And then the other one is pernicious anemia, which is one of the forms of anemia which can happen, which is associated with PBC. And it's the one where you need B12 injections. There's bound to be people on the call today who have B12 injections. But it isn't part of the normal workup for anemia, so it can get missed. So those are the 2 just to particularly be aware of. Neither is a problem once you diagnose and manage them. And anybody who knows anything about PBC should be able to pick those up. But Collette and I have been talking about issues today where sometimes people who think they know about PBC don't, and so always worth remembering to mention that you've got PBC when these things pop up.
100%. By the way, my dog Holly Jones has got she's got pernicious anemia. She's got a lack of vitamin B12. She gets her injections and she's cool.
So we could do a whole session on animals and autoimmunity. So we could do a whole section on that. So, for example, German Shepherd dogs get Crohn's disease.
Wow.
Lots of people know. And my cat developed thyrotoxicosis, an overactive thyroid disease, a few years ago. And we took her to the vet, and she had very abnormal liver blood tests. So the vet said it's likely to be an associated autoimmune condition with thyrotoxicosis. And I said it's very unusual because thyrotoxicosis autoimmunity is very rarely associated with autoimmune liver disease. To which the vet said, "You're not an ordinary pet owner, are you?" And I said, "Nah." So it was just fast heart rate. So pets and autoimmunity, we can.
We'll think about doing that for next year, but don't hold your breath.
For Christmas. Pets and autoimmunity.
Right, we move on. What happens if now? There's a few questions in here. So what happens if urso and OCA don't work is the first point. Yeah. 3 months, the ALP, after 3 months treatment, the ALP went from 185 to 201. Do other people not respond? And the consultant's not contacted me. Now that's 3 months. I don't know if that's the early days yet, but all comments appreciated, Professor.
Okay, so I saw this question in the kind of advanced set, and I think it's a really important one, and I'm just going to a little bit of detail if that's all right, because I think this is going to be an emerging question as we go along.
Yeah.
At the moment, we use cutoffs for blood tests for whether you're seeing a response or not. And so we're largely looking for an alkaline phosphatase to reduce with the treatments we give. and ideally to be normal. So a cutoff slightly depends on the lab that's measuring it, but it's usually around about 200, something of that order. Now, so there will be people who take URSO who don't end up below 200. Okay, so that's what we're looking for with therapy, and they won't end up below 200. Now, slightly, one of the things to think about is where you started from. So clearly, if you started at 1,000 and it was down to 201, although it's not below 200, that's a heck of a response. Mm-hmm. So although that's technically non-response, it clearly is response. If, however, it was 201 and stayed at 201, that's non-response. So you can't just look at the 201, you have to kind of look at where you started from in terms of whether you continue with that treatment. So where people with URSO don't respond, i.e. they end up above 200, we always tend to continue the URSO. And the reason for that is twofold. One is it has some effects in the disease that go beyond the blood test, which is important to know. And the other is some of the data from UK PBC, which many people in this call will have taken part in, filling in our questionnaires and sending them back to Cambridge, show that actually the quality of life of people with PBC is significantly improved by URSO as a whole. Although it's difficult to know exactly what's improved, but if you measure global quality of life, actually, it's better in people on URSO, and it's the thing that makes a difference. So actually, and we published that earlier this year, and actually, you know, it proves that there is some value with URSO almost regardless of anything else. It's also cheap, it's also safe, and I think it works in lots of different ways. So it's kind of, think of it as, and I am not somebody, I mean, with my dashing good looks, I'm not somebody who tends to think about makeup, but think of this as foundation, if you like. Is that right? Is that an approach? Anyway,
that's very good, but depends how many layers.
That as foundation. It's a bedrock of what you do. So if you haven't responded to URSO and you're not having any problems with it, I would continue with it anyway, because response and non-response is a bit more nuanced. Now, the issue then is, what about the other therapies? So if anybody, quotes, doesn't respond to URSO, where we are in 2021 is that they should always be considered for an additional therapy, and that they should be involved in the decision about it. Okay, so there should be a discussion between you and your doctor about the pros and cons of other therapies. And that's very clear. It's in the guidelines. It's in the standard British guidelines, in the European guidelines. It's very, very clear. It should be thought about, and you should be involved in the discussions. The pros and cons should be considered. And there are basically 4 outcomes that should come from that discussion. One is you and your doctors or nurses together decide not to go for additional therapy at the moment. Okay, so if your alkaline phosphatase is 201 and you've, you know, been diagnosed with cancer and you've got a lot else on your plate, then you can wait. It's not something that needs to be done urgently. So it's entirely appropriate in some circumstances not to take an additional therapy, but that should be an active decision. That shouldn't be by default. You should discuss it and decide not to take the therapy rather than not discuss it. The second option, and the one that's licensed, is obeticholic acid, or OCA, Ocaliva, and that is the treatment that the BNF, the drug book the doctors have, should be used in this situation, and that is increasingly being used across the whole UK. Actually, it's not being used in Northern Ireland, which is an issue and a concern. So it's the rest of the UK. And I think we can come back to that in a second. The third option is Fibrate, which is licensed to be used in people. It's an approved drug, and it was approved for use in lowering cholesterol. It is not, however, licensed for PBC. So it's in a slightly more grey area, and it has some pros and cons compared to OCA. Its pro is that it doesn't cause itch, whereas OCA can do sometimes, or make itch worse. And in fact, Fibrate almost certainly improves itch. So it really has a use in people who've got troublesome itch, because it really is kind of beneficial in that situation. It has some downsides, one of which is we know less about it long term. Ochre has been involved in clinical trials with detailed follow-up for 6 or 7 years now. So we've got many thousand patient years of experience with it. So we know that nothing happens to people, you know, once you've been on it for years. It just remains effective and no side effects. So it's a reassuring treatment to give long term, because we know long term it's safe. We don't actually know that about bezafibrate, and I think there are some potential concerns about kidney issues and liver issues with it. So it really does need to be just kind of used with your eyes open. And then the other option is trials. So sometimes your person with 201 might think, well, hang on, there's no urgency to go on to treatment. Perhaps I would like to take parts of the trials of the newer generations of treatment, which I think will eventually replace both ochre and urso, probably. So that's an option for people to think about. So everybody who's not a responder to urso should have that discussion. And I think if you're not having that discussion with your doctors, go in and say, am I an urso responder? Yes or no. And if the answer is no, the next question is, what are you going to do next? Okay, own the problem, own the solution. Now, when you start people on ochre, you normally see a very good response. Ochre and bezafibrate, both the same. Within 3 months, you will see a significant improvement in the liver blood test for most people. Okay, very unusually, people don't respond, but it is very unusual. What you do, however, see is what I would call a technical failure again, where perhaps you'll have somebody who's gone down from 1,000 on urso to 800 on urso. You start ochre and they go down to 201. And again, technically they're not a responder, but they obviously are. And so the question is, what do you do in those situations? Now, in the UK, there is no mandation to stop it if people are non-responders. It's clinician judgment. And I would say to anybody that you decide whether to continue it or not, depending on the totality of the evidence. How do you feel? What have your blood tests done? Can you convincingly see any change with it? And I think if there is benefit, I would then continue it. And in the vast majority of people, there is benefit. So I think it's something to have a discussion about. If you haven't responded as we would like, what do we do next? Most people around the world are adding the other drug in. Okay, so rather than stopping the ochre and using bezafibrate, we add the one you haven't taken. So if you've been on ochre, we add bezafibrate. If you've been on bezafibrate, we add ochre. And that's become basically routine practice now. And there is evidence that's now been published to show that you get additional benefit from that. So I think that's pretty clear cut. Usefully, in people who've had itch with ochre, adding bezafibrate both boosts the effect of ochre, but it also gets rid of any ochre itch. So that actually seems to be quite a useful combination. So people start off on a single therapy. They then go into a double therapy, which is urso and ochre or bezafibrate or a trial drug. And if they don't work on that, there aren't really trials that are suitable, then the approach these days is to go for a third therapy. If people don't respond at all to any of these drugs, okay, so if you've been started on urso and you don't have any change, and started on ochre and you don't have any change, then what you should do is with your doctors, take a step back and ask, did you get the diagnosis right? Because remember, there's a bone disease that people might have heard of called Paget's disease. What does Paget's disease do? It puts your alkaline phosphatase up. Okay, nothing to do with your liver.
Of course.
Commoner as people get older. Now, there will be people out there who've got an AMA from very, very mild PBC, which hasn't made their biochemistry abnormal, and they've also got Paget's disease. You've added 2 and 2 together and made 5. So if the response doesn't look like it ought to be, then just question whether it was the right diagnosis. There's no harm from these drugs, but obviously if you're not treating something else, there is a harm from that. Now, for somebody after 3 months of urso, it's a bit early. Okay, it's a bit early. So urso takes a long time to get into. It's what we call a passive drug. It needs to get into the bile pool, so it takes quite a long time to get up to levels. Ochre and bezafibrate work much more quickly. So I think for somebody after 3 months, I would kind of note it, and I would then continue for at least 6 months in total, and then at that point start to see which way the diet, get the graph paper out and show which way it's going. If it's on track to be normal after a year, continue. If it's going to take a month of Sundays to become below 200, start having the discussion about second line therapy. So the UK approach is largely not to stop therapies because of, quotes, non-response, because most people who are not responding, in fact, are just responding in a way that isn't detected by the blunt instruments. But if you are a non-responder, you might need to add something. Clearly, if it's side effects, then it's a different matter, and it becomes important to look at alternatives. But for most people, it's this. This is going to become a live question, and I think we need to know, this sort of royal we. Are we still allowed to say royal, or is Scotland a republic now?
Don't remember. You start that for a morning, you. Okay. I'll mute you.
Okay,
We're anyway, never going to be a republic. So never.
The presidential we, let's be nice to Scotland. The presidential we need to know if people are coming up against you haven't responded, and we want to stop it, because that's not good practice.
We need to know this.
Now that might be good practice if you've got side effects, or you don't like the drug or whatever, but sometimes this is being done for cost reasons, and the person who's gone from 201 to 201 is not the same as somebody's gone from 1,000 to 201, and it should be based on you, your benefits and your needs, not on the NHS budget.
And anybody who, and I know that's been happening in Scotland, and
I think we need to know about it, because we need to then issue guidance on it. It's very clear in the guidelines that we don't do this, but it is creeping in.
Okay, so we're going to stay on this for a moment. Now, the third question you were sent, it wasn't clear. I've asked for a rerun. I've got a rerun, and I've got something from Anne Houston on the screen. So I'm going to give you this rerun. I've had PBC for 11 years, no symptoms. In January, I was put on 5 milligrams of OCA, and 2 months after 2 months, routine FibroScan, it went from 5.9 to 10.9, which concerned me. I was given another FibroScan in December and told it's increased to 14.5. All of the bloods have decreased: alkaline phosphatase 45 to 279, GGT 300 to 199. The fibrosis has risen dramatically since taking OCA. Could you please advise if OCA could increase fibrosis? So I think they're reading the fibrosis from the numbers on the FibroScan. Yep. That's a very, very good question. And then we're going to look at
a very, very good question. So, so I'll tell you a story in a second. Ochre, so urso kind of changes the bile acid pool, and so it kind of replaces toxic bile acids with non-toxic one. That's how it works. It's kind of like a dilution. Whereas ochre is an active drug, and it binds onto a receptor in cells, and it changes the way those cells function. Now, one of those changes is to switch off bile acid production. So it's like a much more potent anti-bile acid effect than urso. But it also has other effects. And one of those is to reduce inflammation. So it switches down inflammation in the body. But the other is to switch off fibrosis, or to reduce fibrosis. So ochre does not make fibrosis worse, okay? It makes fibrosis better over a length of time. And I think we're going to start to see some of the data to show that, but it's a length of time. So in terms of a side effect of ochre, fibrosis is not a side effect along that. It can't biologically cause fibrosis. It can only reduce it or leave it the same. So when somebody's had a FibroScan getting worse like that, it means one of two things, one of which is overwhelmingly more likely than the other. The overwhelmingly less likely thing is that the fibrosis of the disease is getting worse rapidly, okay? So that's overwhelmingly the less likely explanation, but that's the one that people would worry about. I don't think it would be the drug doing it, it would be the diseases doing it despite the drug, would be the way I would think about it. So why don't I think that's likely? It's because PBC just doesn't behave like that. PBC just doesn't behave like that. PBC gets worse if it's going to get worse over years. So it does it progressively. So that's just not how it behaves. And I think the only exception to that is where it's overlapping with autoimmune hepatitis, and the autoimmune hepatitis component is very aggressive. But that just does not feel like a real change in PBC. Okay. And that's just based on, I mean, I know it's impossible to imagine, but I've been doing this for 31 years. I mean, I know it's impossible to imagine. How could he be so young and have done it for 31 years?
I was thinking the same myself.
Indeed. So I just, you know, over the years, I've seen thousands of PBC patients, and it just doesn't do that. So the most likely explanation is that it's one of the weaknesses of FibroScan as a technology, which is it's an indirect measure. Okay, so what FibroScan doesn't do is actually measure the amount of fibrosis in your liver. What it does do is measure how rigid your liver is. Okay, now if you were to do a little experiment, which is to take a balloon, okay, blow it up with air and do a FibroScan on it, it will be a really, really low value because it would send a ping out and there's nothing for it to rebound off, okay? If you filled that balloon up with water, okay, and did a FibroScan on it, you would actually get a much higher value because more of the ping would return because water is denser than air, okay? If you were to put that balloon in the freezer, okay, with water in it, and do a FibroScan, it would be well over 20, okay, which is in the cirrhotic range, okay? So your balloon with frozen water in it by that point would have cirrhosis, okay, because 20 and above is cirrhosis, okay? Now, clearly that's absurd, but I can tell you, because we've done it, that that's true, all of that's true, because what FibroScan does is send a ping out, measures how much comes back, and how much comes back depends on how solid the tissue underneath it is. It's as simple as that. So anything that makes tissue more solid for whatever reason is going to increase your FibroScan value. And we do know that FibroScan values will fluctuate due to inflammation of the liver, due to blood flow in the liver and all of those things. So you will get short-term variations. And it's really important when people look at FibroScan values that they contextualize it and you apply what I call the sniff test to it, which does it sniff right? And if somebody's got a rapidly increasing FibroScan value, then in the context of PBC, I would take a step back and be very cautious about that. It could be the person doing the tests, it could be the machine, it could be just the day on which it was done. The story I'm going to tell you is of somebody who had very mild PBC, okay, had a FibroScan done by a young and enthusiastic doctor, and the FibroScan was normal, which is marvelous. And then the young and enthusiastic doctor did a repeat at 6 months, which was in the cirrhotic range, okay? A disaster. Cirrhotic over 6 months, can't have been managed properly, lots of scary conversations. And of course, what you had to do after you'd seen this rapid deterioration in the liver was do a liver biopsy to confirm the cirrhosis. This poor lady had a nasty bleed after the liver biopsy, was quite ill. The liver biopsy, incidentally, was completely normal and had no cirrhosis, or in fact, no PBC, okay? When she came back to the clinic, she had a FibroScan done, it was normal again. Now, I can't explain, I wasn't there on the day, I can't explain why that was there, I can't explain why it was high and then low again, but it happens. And I think you therefore, what should have happened there is to look at the rest of the story. Here's somebody who's really well on therapy with normal tests, no other things to be worried about. They just haven't gone to cirrhosis in 6 months, they just haven't. And so it's a bit like if you have a blood test done, it shows you potassium's always normal. You know, people who have high blood pressure get their potassium levels checked all the time. Every so often, baby doctors will come across a result where somebody's had a potassium's normal, then they have a test that shows it's 20, and everyone panics and, you know, rings the renal unit to sort out dialysis and stuff like that. Now, anyone would tell you, you can't have potassium at 20, it just doesn't happen. And so therefore, it's because the blood cells are broken down in the tube. So what do? You check it again, and then you find it's normal. I think it's what's called judgment and just context to it all. Now, how would you tell the difference? Well, what I would do is do actually, and this is just a suggestion, I would do two things. I wouldn't do a liver biopsy for reasons I've just explained. What I would do is two things. One is I look at the platelet count, okay? This is one of the standard blood tests. People do it all the time. And it's one of the cells in the blood. And platelet counts go down in people with cirrhosis. And so if your platelet count is low, then it increases the possibility it's real. And actually, I'm a big fan of, I don't like whizzy new technology. I quite like platelet counts because they cost next to nothing, and they are very useful over time. So track your platelet count, and if it's falling, the magic number is 150. If it goes below 150 in somebody with a high FibroScan, then it's much more likely to be a real thing. And then the other one is just to do an ordinary ultrasound scan. So FibroScan is a form of ultrasound, but it does a measurement rather than a picture. And just do a picture ultrasound. And you'd be asking for two things. One is the spleen big, because that gets big in people with cirrhosis. The other is just to look at the texture of the liver. So what I would do is put an ultrasound request and say, slightly anomalous FibroScan finding, query physical characteristics of cirrhosis. That's what I would do. But most of all, I wouldn't worry about it. Okay.
Okay, that's a great answer. I tell you, the questions are hammering in. We're quickly going to do this one here with Anne Houston. If no reversal doesn't work after 3 months of taking it, there's a possibility that OC won't reduce alkaline either. I think we've covered that.
Yeah. So
far, your alkaline level has gone up after taking it for 3 months. My consultant hasn't contacted me. I spoke to the nurse. It's good that you spoke to the nurse. If you feel you want to speak to your consultant, email him.
Yeah.
And ask him, because I think there's more to this story. But you must do that. You got anything to add to that, David?
No, other than to not respond at all is unusual. To go up with it is unusual. And I would therefore just have that kind of, we were talking about earlier on, we were talking about what I call the arc of knowledge, which people will come across with doctors sometimes. And when you start out in all of this, you know nothing, and you realize you know nothing. And then sometimes you learn a few things and you believe you know everything, and you're at the top of the arc. And then over time, you realize as you learn more and more and more, you realize how little you actually do know. And so, and when you, and again, it's the extraordinary 31 years, when you reach my stage, you realize that nothing's ever in black and white. And so you question everything. So the commonest thing we do where things aren't behaving the way we would expect them to, is to just go back and look at it again. I think where I look at where things go wrong in the management of people with PBC or AH or things like that, the mistake people don't do is to question it. They kind of just blithely continue with plan. Oh God, I'm not going to say plan A. That's awful, isn't it? Plan A and plan B. They just blithely continue with what they'd started doing, and they don't step back and say, "Well, hang on a second, is there more to all of this?" So I think it just probably needs a rethink.
Okay. I'm going to hammer through these now, David. I'm going to hammer through these. After being diagnosed, how often should you get your bloods done?
Depends what treatment you're on. So somebody who is stable on urso and responded quite well, once a year is fine. Somebody who's just been started on urso, we would tend to check them at 3 months and 6 months just to see the direction of travel. If you've been started on OCA, again, we would check it at 3 months and 6 months thereafter to once a year. And if you're on Fibrate, a little bit more frequently, because it can sometimes be a little bit more tricksy, perhaps every month for 3 months, then 6 months and a year. And the other one to watch out for is rifampicin for itch. You need to check it at 4 weeks and watch it quite closely. So we probably over measure blood tests because we then don't act on it. So just 3 with Urso, 3, 6 and 12 months, and thereafter if everything's stable, 12 months.
Next one's an easy one. Can you give me a list of best fruit, vegetables, meat and fish to eat with having PBC? I live in Spain, so you can take this into account. All of the above, enjoy them. You'll have probably a lot more fresh than what we do here. I'm not, you know, I think people should have a very, very varied diet. Just watch it on sugar. I think so the main thing to just watch out for is fatty food, okay?
Because people can be fat intolerant, okay? You know, deep fried Mars bars and things like that are a problem.
Pack it in. It doesn't happen in Edinburgh. That's the other side of Scotland.
Of course not. So fatty food can often be a problem. It doesn't cause any harm, but it can sometimes give you gripey pains and loose bowels. The right level of antioxidants and things is very important. So lots of green vegetables, lots of fruit, and most of all, a balanced diet. And I think if you go into the history books, there was a lot of stuff about avoiding protein in liver disease or having a high protein diet and this, that, and the other. And in all truth, those have kind of gone out of the window. The important thing, as I say, is just watch for fat intolerance. And there is a small group of people, we see them much less frequently than used to, who really struggle with nutrition, who have low body weight and who struggle with weight, sort of tiny PBC patients. I haven't really seen anybody like that for a few years. In those situations, the dietitians are incredibly helpful because there are ways of giving nutrition which bypass some of the issues around PBC. So it's quite technical. Actually, fat in a diet is useful for calorie load. And if you can't eat any fat at all, you can sometimes struggle to get enough nutrition. So I think if you live in Spain, brilliant. I'm very envious of you. But you're in a world with a Mediterranean diet, which is very good. Plenty of fresh fruit and vegetables. Fish is fine. And
olive oil is good. Olive oil is a preference to butter.
Yes.
And you don't need very much of it either. And you don't want it spoiling the flavour of your food. Right, I'm hammering on. I was diagnosed with PBC last March. I'm a female. Also have alpha-1 deficiency SZ phenotype. I've additionally been diagnosed with cutaneous mastocytosis. But I'm waiting to see a hematologist to test for systemic mastocytosis. I'd be very interested in your opinion. And have you come across patients with mast cell activation disease and PBC? A quick answer, because we're stacked up here, David.
No.
Right.
No.
Okay.
The thing to watch out for, just can I pass an additional comment? So that's a coincidental diagnosis, okay? And both need treating in their own right, on their own merits. My only observation about the alpha-1 antitrypsin deficiency is that, so alpha-1 antitrypsin deficiency causes liver disease. And it causes 2 types of liver disease. In children, it can cause very severe liver disease in its own right. And in adults, it can worsen other types of liver disease. Okay, so where I mentioned my sniff test, if something isn't quite right with somebody with PBC, if they're not responding as you would like, or it's worse than it feels like it ought to be, then when you investigate it, it's often the case that a mild form of alpha-1 antitrypsin deficiency is there. The alpha-1 antitrypsin kind of sits in the liver cells and damages them. Now, there is nothing to be done other than to file that bit of information away. It's not an association. The 2 diseases aren't linked, but they do add up a little bit. And so whereas we would pay attention to detail and getting maximal control in everybody with PBC, for you, it's absolutely essential you get maximal control. And you would be somebody we would absolutely want to see normal liver blood tests from a PBC perspective, because you've got this potential additional factor. So it's an important diagnosis. You don't do anything with it, but it means that you treat the thing you can treat as effectively as you possibly can.
Excellent, good. Last time I listened to a webinar with Professor Jones, your good self, and he talked a bit about yellow fever, and he said
Yes.
it played havoc with PBC. Diagnosed, I know, in 2006, and knew very little about. Started on August 2006. I went to Uganda and had to have a yellow fever vaccine. When I returned home, I started feeling ill, and in October developed jaundice. I was diagnosed with AIH, PBC overlap, later confirmed by a biopsy. I started prednisolone and azathioprine. Could this have been caused by the yellow fever vaccine? Yes, no.
Yes. Yes, that was what I was in a sense alluding to. So yellow fever vaccine is a very weak vaccine. Okay, it's not a very good vaccine, very old vaccine. It's what we call a very dirty vaccine. And because it doesn't work very well, it has a lot of what we call adjuvant in it. So adjuvant is a bit like, explosives underneath it to make it really work hard, to really push the immune system. So if you give people a lot of adjuvant, then it just switches on the immune system. And if it was teetering on the brink of developing an autoimmune hepatitis, it can push it over the edge. Okay. Now, so I've certainly seen that. I mean, I've seen that exact thing. The kind of good news is that those types of autoimmune hepatitis, so I don't think it will cause PBC. I think it does precisely what you've just described, which is cause an additional element with it. The good news is when any drug causes autoimmune hepatitis, it's usually very mild and it settles down of its own accord. Because once yellow fever, once the explosives is gone, there's no pressure behind it. So it's something that is likely to be treated and then will bring it under control, and you're not going to get the vaccine again. So it could have done. Is there anything that you would do with the information? Well, not really, because what you're describing is a heck of a lot nicer than yellow fever, which kills people. So I think it's one of those tricky ones. But at the end of the day, vaccines work by causing the immune system to be activated, and in people with PBC and things, you don't want to have an immune system activated. Now, just to be really clear, COVID vaccines do not have adjuvant in them. Just be very clear about that.
Thank you for saying that. Was my next question.
Very clear. They do not have adjuvant in that. It's the old-fashioned rabies vaccine. It's these, ones that date back because they just didn't know how to make vaccines. So, the modern vaccines, hepatitis B and things like that, are incredibly cleverly built so that they really laser in on what the immune system needs to do. So you don't have this, very broad effect. So that's really important, particularly the Pfizer, BioNTech vaccine. It's very sort of sophisticated in how it works. So that's a really important thing to say.
Okay, now I'm going to screen here. This Joel is in America, and I suspect that your question, it seems black and white, but I think there's more to it. My PBC levels are good. Thoughts on donating a kidney. Kidney function has always been good. I think it's much, much bigger question than what you're asking. I don't think it's necessarily down to your kidney and your liver. David?
So which question is that?
It's on the screen from Joel. My PBC levels are good. Thoughts on donating a kidney.
Oh, okay.
Kidney function has always been good. I think the question is much bigger than just liver and kidney function.
Yes, I mean, I think in terms of organ donation, PBC would not be a contraindication to that at all.
I've lost you, David. Come back.
That we used to see in PBC, but almost never see now. But that's a kidney sitting in a body of somebody with PBC. So I would have no hesitation. I would have no hesitation receiving a kidney from somebody with well-controlled PBC, or a member of my family with that. So I think that shouldn't really factor into it at all. The other thing, of course, you do have to just, if we get this blood donation rather than organ donation, is just beware about total ignorance. because certainly in the UK, anybody with a liver problem is not allowed to donate blood, or certainly didn't used to be allowed to donate blood, which is of course complete nonsense if you're a PBC patient. And what they're really saying is we think everybody with liver disease has got viral hepatitis, and it's just total utter nonsense. So just guard against ignorance around that. Clearly, they're using an abnormal liver as as a reason to screen for something which has got nothing to do with PBC. So it's insulting, it's bonkers, it's poorly thought through, and you just need to push back at it.
Okay. I haven't been started on nursery yet, as my LFTs are still in the high normal range. I will have a Fibrate scan before my next appointment in April. Being told it's there, but at present it's just lying dormant. Is that?
Yeah, I think so. And I think, that sounds like good practice. I think in those situations, so by high normal, I will assume that's within the normal range, but towards the top end of the normal range, in which case that's fine. If it's high, if it's elevated, but below the level, below the 200, so normal, upper limit normal is 120 to 130, depending on the lab. So below 120 to 130, perfect, that's fine. If it's between 120, 30 and 200, which is kind of okay, that's not okay. You need to have treatment. So anybody with an alk phos that's elevated at all needs to go onto urso. So that's perfect. FibroScan, actually, the big use of FibroScan is in reassuring people. That's how we use it, where somebody comes along, they've been found to be AMA positive, they've got, an alk phos that's kind of just below the upper limit of normal. We would FibroScan those people and discuss the result with them. And actually, they go away thinking, great, that's kind of just reassured me. The problem is if you get a rogue result, if you then, that's where you've got to contact.
Yeah, so it's not.
And what we would do in those situations is just somebody checks your blood tests every year, and if it ever becomes elevated, then just start urso at that point. And if they've got access to FibroScan, then I wouldn't do it every year. I would do it every 3 to 5 years.
Okay. Now this is a you need to answer this question. I know you need both a genetic and environmental trigger to get PBC. We're not going to get into that because I'm sitting with so many questions. Could COVID or the vaccine be the trigger? And I was diagnosed and started having symptoms of PBC after I had COVID. Could the vaccine or could COVID cause our PBC?
Yes, there is no evidence of that, but I think it's possibly too early to know. I don't think that viruses are particularly a trigger in PBC. I think they are in autoimmune hepatitis much more. And I have not convincingly seen that in our clinical service, but it's potentially too early to know. I think vaccines we've covered. I don't think, again, there's any evidence. I think you've got to understand both with COVID and the vaccines, we are now talking about many, many millions of people who've been exposed to them. So if there was an issue, I think we would have seen it by now. So my suspicion is not.
Okay. Newly diagnosed.
Remember, it's what we call an ascertainment bias can come into these things, where if you've had COVID or you've had the vaccine, you're more likely to have another blood test done, and you may well find something that was there. It's why one of the commonest times to find PBC is in pregnancy. And that's not because PBC is associated with pregnancy. It's because that might be the first time you've had your liver blood test measured in 20 years.
That's right. Okay, newly diagnosed, have a small cyst on the left lobe, so being monitored 6 monthly by the Royal Free team. Great. I'm AMA positive with mildly elevated GGT. My dad had a transplant in 2018 for PBC, and my nan also had it. Is there more research being done looking into family links history? Now, we really are going to have to be short on this. What it was explained last week, there was only 20% of people with PBC that have a close relative. But the question is there research being done? And that's something that you know a lot about.
Yes.
Very briefly.
Yes. So two things to say to that. The first is, yes, so families with PBC, where with more than 2 people in them are very helpful indeed for helping us understand the disease. And this is what George Mells and Dick Sanford, my good friends and colleagues in Cambridge, do. So if you aren't a part of the UK PBC study, the Cambridge Genetics Study, then please think about joining it. And when you Collette can give you the details about how to do that. But when you send the paperwork in, mention what you've just said and they'll be in touch. So absolutely, you can really help because and particularly a father or a male with it in the family, I think is very helpful. So you can really help. The other thing to say, is you're AMED positive with an elevated GGT, okay, but a normal ALK phos. Is that PBC or is that not? To me, that's PBC, and I would always treat that. So gamma GT or ALK phos elevation, I would always treat, okay? And that if I had 2 relatives in the family with significant PBC, I would absolutely always treat. And to be honest, I would always have a discussion. So if you'd come to our clinic with an AMA and otherwise entirely well with that family history of significant PBC, I'd have had a conversation with you about starting preventative urso. I wouldn't do it in people without that family history, but for 2 reasons. One is there's something going on, and the other is, human nature says you're wondering if you're next. So I would have had that discussion, and if you haven't had it with your doctors, I would have it.
Yeah, and they're all free. I'm sure they will. Drugs on it. Okay, I was diagnosed July this year with a positive M2, SP100 and GP2110 were negative. Had a hospital appointment in November with a liver nurse, and another autoimmune liver blood profile was done unnecessarily, I believe. I don't know why. This showed that my GP210 was weak positive. Should I be concerned about this?
No.
Yes. No. Right. Okay. Move on. What vitamin supplements and dosages can be taken safely if the PBC sufferer is deficient with certain vitamins, i.e. vitamin A, B, D, E? So what vitamin supplements can be taken safely if the PBC sufferer is deficient? If you're deficient in vitamins, then you have to let your doctor decide what you should be having. If you've not had blood tests, I'm not a doctor, I'm just telling you as a patient, if you've not had blood tests and you're not sure, ask for them, get them checked out, and be guided by your doctor. Would you say so? Because you can overdose in these things as well, can't you, David?
You can. Which is the answer to the question, what's the only bit, which you've never asked, but what's the only bit of a polar bear you can't eat? And the answer is it's their liver, because you get vitamin A poisoning from it, okay? So if anybody goes on Who Wants to Be a Millionaire, and that's the £1 million question I want to share, because you know the answer. So because the polar bears have a very fatty liver, they dissolve a lot of vitamin A in it, and it's actually toxic.
Oh wow!
So the answer is actually this is life is very easy. So the vitamin industry is a very good one. It's very well regulated, and so all the preparations you can buy at a pharmacy or in a supermarket are the right formulated doses, and you're not going to go far wrong sticking with their standard doses. Okay, so that's one of the things that makes life very easy. You don't have to worry about it. The only thing to say is that A, B, D, and E all share the characteristic that they're fat soluble, and so can be low, particularly in PBC, if you're having problems with absorption from the diet. In which case, it's not the amount you're taking that's the problem, it's the extent to which it's absorbed from your diet. In which case, you might want to take a slightly higher dose, and so perhaps 2 tablets rather than 1 tablet. But again, if you're taking 10 tablets a day, that's too many. If you're taking, half a tablet every fortnight, that's too little. Somebody once told me when I was a junior doctor, the correct dose of anything is 2 tablets or 1 vial for injection. And it's the most useful bit of practical information I've ever had, because if you think that the dose is 100 tablets or 1/10 of a tablet, you've got it wrong, because whoever makes the tablets has worked out what the right dose is practically. So it's very safe. My point about polar bears is you have to take a lot of vitamin A, but just the standard dosing, nudged potentially upwards if low weight has been a problem.
Okay. Is it recommended or helpful to go on a gluten-free diet and or lactose-free diet? These foods seem more difficult to digest and our fried foods and fatty foods definitely, I don't know why they mean provided, but if I think it's one of those, a very individual thing. If these things are irritating you, then it's probably best to keep them at a minimum with your diet. And fried food isn't good for anybody, you know.
Yes, yes. Do you do battered pizza in Edinburgh? Is that also Glasgow?
No, we do not.
Okay. So fatty foods, as we've discussed, is a perennial kind of, can be a perennial issue. So be aware of that. Gluten sensitivity and lactose intolerance are very specific problems. And actually, one of the things that's happened in our world is there's been a sort of normalization of gluten-free diets and, you know, lactose-free diets. And the only reason you'd need to do that is if you're truly lactose intolerant, which is an enzyme deficiency, or you've got gluten sensitivity, which is an immunological response. And so therefore, I wouldn't do that unless you've got, you know, good evidence that there is an issue. Now, you know, gluten sensitivity is celiac disease. There isn't really any good evidence at all that people are intolerant of gluten other than with celiac disease. And that's a formal medical diagnosis done normally with blood tests these days. So that's one to discuss with your doctors. But it is commoner in PBC than it is in the otherwise population. So it is something to be aware of, but it's still less than 5% of people. In that situation, gluten-free diet's very helpful. Sorry?
Oh, so I was going to say, you've got another one on the screen talking about the same thing.
Yes. So lactose intolerance is usually very dramatic, which is very, very soft stools indeed when you drink milk or milk-based products. So again, that's usually very characteristic. So what I wouldn't do is go dietary adjustment for those reasons, because one of the things you can end up with is people stripping 101 different things out of their diets and ending up actually with nutritional problems. And I've only ever seen one child with kwashiorkor, which is the massive protein malnutrition state that where children used to have very swollen tummies, horrible state. That was a child, but that was a child of very affluent middle-class parents, and it was as a result of an extraordinarily obsession about sort of not particularly real dietary intolerances that actually almost killed the child. So don't go too far without any evidence to support it.
And you'll see that some lady on the screen, she said she had a lump in her thyroid gland or swollen thyroid glands. She reduced her gluten and it's reduced by about 35%. So we've answered the question about
and I think in that situation, so swollen thyroid is usually part of the spectrum of autoimmune thyroid disease. So you can get swelling with all of those, although you can get tumors as well. So it needs investigating, but it is linked to gluten sensitivity, absolutely. But we're talking there about this real, you know, diagnostic process. And I think, so as I say, I mean, you're not going to hurt yourself by going onto a gluten-free diet. It's just horrible food. Because, you know, you take all the nice things out of life. So it's worth getting it formally diagnosed because it will make life easier.
How are you for time, David? Because
I have until 10 past.
Right, okay, let's go for it. Can a very small liver cyst, 3 millimeters, be related to PBC?
No, born with it. It'll be there.
Can you have a long life with PBC without progression to cirrhosis? Yes. Yes, our oldest lady died of 103, many people in their 90s. You get anything to add to that, David?
No, I absolutely agree. And also, you can have a very long and totally healthy life with cirrhosis. Because I know somebody who had cirrhosis. I did his liver biopsy. He had cirrhosis on his liver biopsy. This was a long, long time ago. And he never once had abnormal liver function tests. And he died in his 90s of something unrelated to PBC after 25 years.
There you go. Can you examine the bile ducts with something other than an MRI scan?
So, and presumably this is because of claustrophobia with it. And, you know, for those people, yeah, I suspect so. So the first thing to say with that is that there are open-sided MR scanners and they are getting better. So actually, the first thing to say, if it is claustrophobia with an MRI, is to talk to your clinicians about whether you can get the MRI done somewhere else where there would be a scanner. So technology is improving out of all recognition with the scanners. And I hate having MRI scans. I had one done years ago in an old-fashioned scanner and literally hated it. And then I injured my knee and had it done in a modern scanner, and it's extraordinary the difference. So that's the first thing to say. The old-fashioned way of doing it is with an ERCP, which is where you do endoscopic test and put dye into the bile duct, but you really want to avoid doing that unless you absolutely have to, because it causes, because the dye can actually irritate the pancreas and can cause health problems.
So
there are some older types of, oral cholecystograms, used to call them, where you used to swallow a dye, but nobody's sort of done all of those. So I think if it's about claustrophobia with an MRI, think about an open thing. If it's about metalwork somewhere in the body, then that's more of an issue, although it tends to get a little bit overstated. So the main issue with MRI is actually it can distort the images rather than it being a particular problem. The one exception to that is clips on aneurysms, where it can move them. So that's the other reason why not. So, and if you really can't, you don't want an ERCP, you really can't do an MRI, then actually you do what's called a spiral CT. So the older CT scanners, they, rather than doing a single image across, they can rotate around and they can actually give you reasonable information. So on a transplant unit like ours, you will come across people who just can't have an MRI. So we would do a spiral CT, and it kind of is pretty good.
Yeah, great. Is vertigo connected to PBC? I also have Sjogren's. I've now had dizziness for 2 months. I'm hoping this person has actually taken that to their doctor, but is vertigo connected to PBC? So true vertigo isn't, okay? So true vertigo is where the world rotates around. It's like you just feel like if you've got off a roller coaster, okay, where the world literally rotates around you. Sometimes people think that dizziness when they stand up, lightheadedness, is vertigo, but it doesn't have the rotational component. So the dizziness and lightheadedness is associated with PBC through low blood pressure and autonomic dysfunction, and actually is associated with fatigue. It's one of the things we kind of treat. True rotational vertigo isn't, although it may be with Sjogren's through the ear effects, which are, so if you don't have saliva, then you can end up with eustachian tube problems, but that's not my area. So I think it's possible, but the key thing is it true rotating world? Okay. Diagnosed with AMA positive 2 years ago, all blood's normal. I do have periods of chronic fatigue. I take iron supplements which seem to help. Well, I hope you get them from your doctor. My consultant said he would only prescribe Urso if and when my bloods indicate a change. Well, we've covered that, really. That's what you've said. They're saying,
so my rule of thumb for Urso is if you have PBC, okay, and I would regard anybody with PBC symptoms as having PBC, okay? So we do discuss with people with normal LFTs, and we've now talked about both of the scenarios. One is if they have a particular reason to be worried about this, and it's just that, it's a discussion. Here are the pros, here are the cons, it's up to you. And we also do it sometimes with symptoms, because we did some work a while ago on fatigue and actually showed very similar fatigue levels in AMA positive normal LFT people to those with abnormal LFTs, and we don't quite know the reason for that. So it's one of those things. Now the downside is that you've given yourself the diagnosis, if you like. So from health insurance and travel insurance perspective, you can't argue that you've got a precondition if you're treating it, if you know what I mean. So that's one of the cons with it. So it is something that we sometimes do.
Okay.
And for iron, there is trial evidence that low dose iron can be beneficial even in people without anemia. Okay.
Oh, okay.
Yes. As a treat now, and actually not a bad trial, it was in the BMJ a few years ago. My only thing to say is that iron can be toxic.
Yeah,
so
exactly,
you don't want to go and you don't want to be going and taking large amounts of iron. And again, my Jones's rule about 2 tablets or 1 vial in an injection comes into play. So you don't want to be taking anything beyond.
There is a liver disease. My niece has hemochromatosis, and she has to be bloodlet because she's got too much iron in her liver. So
yes, that's right. So
I've heard PBC can affect your teeth to the point where they can start to crumble. Is this true? No. Or how likely is it? Well, that's the dry mouth syndrome, isn't it?
It is, exactly. So it's dry mouth and just extra care about watching your mouth. And Collette, you haven't said the one thing that you always say and you must say.
What? About the mouthwash.
Yes.
Yes, the mouthwash. Don't be using chemical mouthwashes from the chemist. Salt water, warm water, Granny said. The chemicals in the mouthwash will dry your mouth further, they'll stain your teeth, and they change your taste as well. They are not good for you. Okay.
Exactly.
So, but give me a ring at the office. Well, give somebody a ring at the office. How soon do you think a treatment to stop or even cure PBC will be discovered? David's on it. So we've given you how long are you going to take to find a treatment to stop the progression of PBC?
So sorry, I lost signal in the middle of that.
All right, okay. So how long is it going to take to stop the progression of PBC? Is there work? David has worked in research on PBC all his professional days, and he's
thank
on
you
it.
very much for
He's
that.
on it.
We have just got a grant from the Medical Research Council in the UK, who have supported all our research into PBC. Collette knows this. To answer that exact question. And the question is, if you start obeticholic acid plus urso at the very beginning of the disease, i.e. don't wait to fail on urso treatment, get the treatment in from the very beginning, does it? So we got that grant. That trial will be starting in the UK, we think, around about next Christmas, or the time for the parties in number 10 Downing Street after this year's party.
They don't have parties.
So the answer is the next trials in PBC will be to answer that exact question. And as Collette knows, I believe that we will be able to, if not cure PBC, stop it completely at the very beginning and change the whole of the natural history. And I think we as a community should be ambitious about that.
Absolutely. It's got to be done before I retire. I like to fast regularly. Is that a problem? I feel so much better when I don't eat. That's not a simple question as one would think.
Yeah, I mean, my wife is, who I hope she isn't listening, is an obsessive faster, and as you can see, I'm not, so is very into low carb diets and things like that. So there is interest in fasting and its effect on the metabolism. I don't think that's implicated in PBC one way or another. I'm not an expert on it, but I think it is a reasonable way of weight control. My only thing is that if people have cirrhosis, they can run quite low spiky sugars, so they can go quite low very easily. So I think anybody with advanced liver disease, I'd be very cautious about that. If not, I wouldn't have a view. Okay.
Is the itch worse later on in PBC?
Is the itch
worse in late PBC?
So bizarrely, we were talking about this, weren't we?
Yeah.
So the answer is it can happen at any stage in PBC. Some people get it, some people never get it and have no idea what we're talking about. And we don't understand why that is, but I suspect it's genetics. It's the gene difference between people. It can get worse during the disease if you're getting bile duct injury, but paradoxically, with very advanced PBC, it usually gets better, or often gets better. So itch worsening or improving doesn't tell you anything about the disease. And I think one of our, kind of mantras of what we do is you treat itch as itch, you treat fatigue as fatigue, you treat, disease severity in PBC as disease severity. So you kind of, I always talk about the drop-down menus for each of those things, which is you pull the menu down for each of those and you treat them on their own merits.
Well, you've done marvelously well.
We got one more. Time for one more.
I haven't got any. That's the lot.
No, I've never done that before.
The lot. That's fantastic. I think you answered more than 30 questions. So we get a message here. Thank you. Sending Christmas.
Can I just say, you might want to point this out to Robert, that clearly quickfire works much better with you. I don't know if I just naturally obey you more.
Oh no, that's what it is, because I'm much older than you. You're too scared to get a clip in the ear.
Is that right?
That's what it is. Yeah. Now I want to thank everybody who's watching and listening who sent these questions in. And we did a bit of a survey and we took this to the trustees meeting. We know that this is one of the favourite things that you like, and we're going to continue doing it. We're not doing any more for the rest of this year because all the staff and the doctors need a rest from us. 13th of January is our first one, and guess who we've got? Professor Jones back on the 13th of January.
And can I just say on behalf of the kind of clinicians in all of this, I think we love doing this. I think you can tell. And it's been an eye-opener, just the value of this. And heavens above, there haven't been many positive things from COVID, but this is one of those things that, you know, we sit here and think, why didn't we ever do this before? Why did we never do this before? And I think we will continue to do this because, you know, and again, these are brilliant questions. And actually, these are new things that are coming out. And I just think, we love doing it. We love the fact that people find it valuable, and I'm just, you know, slightly wondering why we didn't do it before, but we're doing it now.
We are doing it now, and it's well, we've all got different experiences with our GP throughout the country, and I'm very lucky. I've got a lovely GP, but not everybody's getting access, so it's important because, David, some things that have been picked up in these sessions that needed to be picked up, and we were alerted to the fact that somebody needed help very quickly. And that's happened on a number of occasions.
And I think that's right. I think we're, one of the things is we're all very experienced at dealing with these sorts of things. And so, you know, where people do raise things with us, if it rings alarm bells with us, we will not just let that, you know, we're there to kind of give people advice. And please, whatever you do, if you're not getting treated properly, don't accept that because you don't want to upset the doctor. Okay. Don't hurt yourself by not wanting to cause a fuss. We need to be, as I always say, more like the Americans who get exactly what they want. So, you know, it is the only way we get better practice, better management for everybody is by repeatedly working on pushing the standards up. And I think it's educational for everybody, and, you know, just get what you want and deserve. And I think in COVID and all of those things, you know, we are very worried about the extent to which people's kind of management has slipped or been neglected with that. So please do just push and push.
This is why they're so important. It's not just about answering benign questions. This is about, you know,
own, you know, the mantra, own the solution.